Hi, everyone. Welcome to today's live Q&A with Dr. Matthew Taylor, Dr. Keegan Zimba, and Stacy Seslowsky, Registered Dietitian. They're all the team here at Tegrity Health. Tegrity provides virtual integrative medicine, combining advanced diagnostics, precision medicine, and personalized nutrition and lifestyle care to help patients address their root causes and build lasting wellness. This is our monthly AMA where our team is going to answer some of your questions. And so we're going to get started. The first question, Dr. Taylor, is for you. They want to know, what are your thoughts on NAD supplements?
That's a bit of a loaded question, it sounds like. Okay, well, so NAD or nicotinamide adenine dinucleotide, this is, we'll say, real biology where the hype is probably way ahead of human outcome data. NAD is essentially cellular currency for the body, and every cell needs it. It's important for energy production in cells, for DNA repair, for signaling different enzymes that are involved in cellular health and immune metabolism. It's a legitimate target in the cell to focus research on, but the clinical question, so to speak, isn't, how important is NAD supplementation? It's more, can we get the NAD into the place where it belongs? So one analogy we could use is NAD being a lot like cellular currency, which every cell needs, is something yet where giving more currency to the bloodstream doesn't automatically mean it's going to get deposited into the right cellular bank account, if that makes sense. So the here is the NAD molecule is quite large. It's also a charged molecule that doesn't freely diffuse through the membrane of most cells. So some cell systems might be able to metabolize some extracellular NAD, such as given through an IV or through absorbed through supplementation. And we're taking that NAD into the bloodstream. But when we look at actual studies analyzing where does this NAD go once it's in the body, whether we're tagging the NAD molecule with something that allows us to track it via like a chromophore or something that gives off light, or just looking at basic membrane studies, we're seeing that the IV or oral NAD supplements that we're giving the people simply don't enter the cell. And so we're not really raising NAD where we want it to be higher, which is inside the cell. And that's kind of where it counts. So most of the human IV NAD work is, we'd say, preclinical. It's really looking at raising metabolites of NAD in the plasma and in urine, but there really aren't proven clinical outcomes we can point to yet. If I had to steel man the argument for NAD supplements like NR and NMN, which are nicotinamide riboside and nicotinamide mononucleotide, these are oral supplements that claim to raise NAD in the body, and probably the best argument for why they might work is in the fact that when you do look at randomized controlled trials that do exist looking at these supplements, the outcome is that they do actually raise NAD levels in the serum, but there we're looking at the proof that they raise something as a biomarker that you can track. It doesn't necessarily prove that we're raising something that can produce a clinical outcome we want. So NMN at least has one of the clearer human efficacy signals. There is a randomized controlled trial that was done a few years back, 10 weeks long, specifically in postmenopausal women with prediabetes and who are overweight. And NMN seemed to improve insulin sensitivity in that population and improve insulin signaling. But that's not really an anti-aging hype molecule or effect. It's a meaningful metabolic endpoint in certain populations. That's probably the extent that we can say about it. So I'd say pretty plainly that NR and NMN, they can in humans, but the best evidence isn't showing that they're reversing aging or that there's some sort of panacea. They're more likely improving a specific biomarker, maybe a cellular stress response, and that might be the extent of what we can say about it. IV NAD, biologically interesting, but the clinical evidence is even thinner. So I think instead of pouring more NAD precursors as supplements into the system, we might learn how can we use methods that increase NAD naturally and increase the body's own production of it. Exercise far and away is going to be the best method for doing that. And while there are some chemicals that have been proposed to maybe do this indirectly by inhibiting stress on what we call the NAD salvage pathway, which I'm getting into some kind of nerdy ground there, but those types of chemicals that exist still also preclinical. So I'd say for the time being, exercise is our friend on the NAD story, and that might be the extent we can say about it.
Very cool. Thank you so much for that answer. Our next question is going to be for Dr. Zimba. They want to know, what is your philosophy on long-term microdosing of tirzepatide after reaching your goal weight, especially when potentially the patient has had colonitis colitis and is helped with remission? So what are your thoughts on that, Dr. Zimba?
Okay, so I think this is a great and very timely topic as we talk about these GLP-1 medications so much more, and we're seeing them used in such greater volume. So tirzepatide, as a reminder, is a dual agonist GLP-1 medication. So it binds to both a GLP receptor and a GIP receptor. So as a result, we've seen greater weight loss outcomes with the tirzepatide over the original Ozempic and liraglutide, which is really nice. And that means, people are achieving this goal weight that they're going for, but sometimes the weight isn't necessarily the goal either. So we hear a lot about microdosing, and microdosing is using smaller than the standard recommended doses of, really any medication, but for tirzepatide, we're looking at less than 5 milligrams, even less than 2.5 milligrams, depending on who the individual is. One of the really cool benefits that we've been seeing is that there seems to be better inflammation control with some of these medications in the right person and with the right condition. And so this person mentioning that they have a pretty significant form of colitis is one of those situations that we have seen that benefit. And so, wanting to avoid relapses and keep someone in remission, the consideration for a microdose is absolutely very valid, and maybe even, a legitimate dose, 5 milligrams, 10 milligrams, 15 milligrams, whatever it may be for that person. I think, looking at two different questions here of weight management beyond that initial weight loss, and then kind of controlling inflammatory type or autoimmune conditions that could be present. And I think both cases see an avenue for ongoing use of the tirzepatide in more of a maintenance fashion. And the cool thing about maintenance that we're learning about is it doesn't necessarily have to be that standard every week dose. The goal is just to get enough stimulation of those receptors that you're still getting and seeing some clinical benefit. So for a lot of folks, especially on the weight loss journey, that comes from simply not necessarily trying to force weight loss anymore, but maybe controlling food noise, for example. And so that can happen with much, much lower doses than where we might try for full out appetite suppression, because that's not necessarily the goal. Once we're maintaining our weight, we don't want to necessarily suppress suppress the appetite fully. So I think using those microdoses can be really helpful. And again, using maybe longer term between doses, which is in a sense a form of microdosing. So if you're using it as a once monthly injection instead of every week injection, you are getting, in a sense, a much lower dose. So that can help, and that can help bridge that maintenance period. And then it becomes, a cost benefit discussion rather than, a weight loss discussion, so to speak. And because it is still depending on the person and their original conditions, maybe may or may not be something that's still covered by insurance, but is still providing a clinical benefit. Someday we'll have all of these things covered by insurance, of course. And then so shifting to the other portion of that, which is the control of different inflammatory conditions, autoimmune conditions, or even seeing it in histamine type conditions like MCAS or mast cell activation. So for those folks, we usually get a lot of benefit from very, very tiny doses of that, much lower than those standard recommended doses, and to get into the remission. And sometimes even with doing all those other things we talk about in functional medicine, which is optimizing the gut and optimizing nutrition and optimizing sleep, sometimes we still need that additional support there. And so it's very reasonable to consider longer term use. And thankfully, we now have years and years of data that we're building up to show that for the most part, these seem to be safe medications. But again, they shouldn't be just used. They should be used when there is that indication. And given the chance, trialing times off to see if, that's truly when the body has now made that point where it can pivot and handle everything on its own and not need the medication. So I think having those discussions about maybe standardly trialing off at some points is important too, before thinking that it's necessarily a lifelong medication.
Wow, very interesting. Thank you.
Fine.
All right, Stacy, this next one is for you. They want to know, how should someone think about carbs if they have insulin resistance, prediabetes, PCOS, or blood sugar swings?
Yeah, so I'll start off by saying that carbohydrates are not the enemy. They are our body's preferred and quickest source of fuel. So when we're exercising, for example, if we are eating enough carbs, then that's going to help us to perform better in our workouts, and it will even help us to recover more quickly. And especially when we are choosing the longer chain, what they're called oligosaccharides, or sometimes people will say complex carbohydrates. Those are ones that are higher in fiber as well as resistant starch. These are things that will feed the gut microbiome. And we know how important the gut microbiome is, that the bacteria in our gut, they help us to digest our food, they support our immune system, and they even impact our mood. So it's helpful to eat these types of long chain or complex carbohydrates, not only to help us perform in our exercises, but then also to keep a healthy gut microbiome. But obviously, if somebody is struggling with big spikes in their blood sugar when they eat these carbohydrates, then we want to make sure we're making the right decisions. So one is that we do want to make sure that the carbohydrates we're choosing are those longer chain or complex types of carbohydrates. So high fiber ones like beans and lentils, resistant starch options like potatoes and rice could actually, if you eat them when they're cooler, then they won't spike your blood sugar as much as when they are very hot, coming right out of the oven. And then also when you combine those carbohydrates with protein and fat, the protein and fat will help to keep the blood sugar a little bit more managed rather than eating those carbohydrates all by themselves on an empty stomach. So you want to make those smart choices, choosing those types of carbs and combining them with fat and protein. And that would be opposite from choosing simple carbohydrates like sugar, right? So we don't want to choose sugar, simple carbs, candy, things like that, we want to make sure that they are those healthier types of carbs and we're combining them with a meal. The other thing that really matters is timing, because if we eat our carbs and then we go do a workout, then that sugar that would normally cause our blood sugar to spike is really just going to be used to help us perform in our workout. So timing matters. If we eat our carbs before workout, that's great. If we eat after our workout, then that could also be helpful, because we're getting still the benefit of that really speedy metabolism that's from our workout. And then if we're eating a high carbohydrate meal and we don't plan on doing a full workout, even just a small 2 minutes of movement after your meal will still help. So climb a couple of flights of steps or do some squats in the kitchen, but that will bring your blood sugar back down again. And I think the ultimate goal is then to understand what is triggering all of that insulin resistance and blood sugar dysregulation from the beginning, right? Because if we have good insulin sensitivity and normal blood sugar regulation, our body will be able to handle these ups and downs, and it will be able to handle a higher carb meal once in a while. So it's really getting to that underlying inflammatory process, insulin resistance, trying to work with somebody who could help you get to that root cause, because then your body will be able to start to regulate blood sugar on its own, even when you're eating some more carbohydrate-rich meals.
Wow, awesome. Those are really helpful tips I think that everyone could benefit from. So thank you. All right, Dr. Taylor, back to you. Your question is hormonal creams versus pellets.
I'm implying a question there. I'll do my best to address it. I imagine the question is over what the big differences are. And I think the biggest differences aren't necessarily in what's safer or better or more natural in how they behave, but more in kind of three direct ways. And those would be control, dosing, and convenience. So if we take them one by one, the first thing and kind of principal thing I want patients to understand is that creams and gels, when using topical estradiol and testosterone specifically, those can be adjusted, whereas pellets cannot easily be taken back. Topical creams and gels usually allow dose changes over days to weeks if if a woman develops breast tenderness or mood changes, acne, hair shedding, things like fluid retention or symptoms of high testosterone, for instance, a clinician can reduce or stop the dose on the fly, and that gives that greater control and adjustability. Pellets, on the other hand, are implanted under the skin and they release hormones over months. That can be convenient. We'll get to convenience, but if the dose is too high or if the patient is having side effects, they may have to wait it out or remove the pellet, which can be a cumbersome process in itself. I think it'd be remiss if I didn't at least mention that the American College of Gynecologists specifically recommends preparations other than pellet therapy for testosterone. And that's mainly because of more limited safety data and then inability to remove the pellet once it's placed. So that's number one. Number two would be dosing, as I mentioned. And with hormones, more is not always better or more youthful. Sometimes it just means more side effects. So topical estradiol and testosterone, they can be titrated down to or up in a lot of cases towards those physiologic range doses, and that gives some symptom response. Pellets may produce higher peaks in the hormone level, especially with testosterone, and that can sometimes push women into a supraphysiologic range or like much higher level of testosterone than what's typical for human biology. This matters because testosterone can be pretty direct in triggering some of these symptoms I alluded to earlier: acne, oily skin, facial hair, scalp hair loss. even irritability, insomnia, and voice changes can happen, those being ones that might not fully reverse in some cases if there's been an extended exposure. And then a couple of things that become sort of the more concerning side effects, things like clitoral enlargement and changes in a person's lipid profile. So for all of those reasons, having better dosing control really matters for some of these things. And then lastly, convenience. Pellets are popular partly because they're convenient. You can place them and then not worry about them. It's also, quite frankly, a convenience to the physicians who place them. But convenience doesn't always mean the same thing as precision, and that's the name of the game with our team. So to that point, it is important to know that compounded creams can be really useful if we're looking for a very precise dose, especially one that's not commercially available, where considerations about absorption varying by site, the base that's used in the cream, the quality of the compounding, and then application habits all factor in. And that gets really into personalizing the prescription. Pellets may be considered by some clinicians where the adherence to hormone therapy is poor, or when a patient strongly prefers infrequent dosing of things. So it's not that they're wrong, they're just, there are other considerations that you have to make. But they are less flexible and they're less guideline favored, if I can say so. So the practical bias ultimately is you start with the most adjustable and measurable and removable or reversible route first. And for most women, that usually means transdermal estradiol, either as a patch or a cream, oral micronized progesterone, whether or not a uterus is present, given there are a lot of functions of progesterone beyond the presence of the uterine lining, and then carefully dosed transdermal testosterone, particularly when there are clear sexual health indications for that. So before choosing a route, I usually suggest people ask 3 questions. Can we adjust it? Can we measure it safely? And can we stop it quickly if it doesn't agree with the person? And the answer to all of those questions generally is yes for the creams and the and gel-based formulations. And that's usually a better starting point than a long-acting pellet.
Awesome. I love the 3 questions. That makes it easy for people to kind of go from there. So thank you.
Sure.
All right, Dr. Zimba, this next one is for you. For someone with mild coronary artery plaque, but excellent fitness, what interventions provide the biggest benefit?
Okay. Well, kudos to having excellent fitness. We love that. But just to help tease this apart a little bit for everyone, mild coronary plaque, what is that? So coronary refers to the arteries around our heart. So our heart is a muscle and it needs to be fed oxygen just as much as the muscles in your arm or your leg. And so we get that from the arteries that are specifically called the coronary arteries that wrap around the heart. Those are also the same arteries we worry about getting blocked up with plaque. So plaque is that buildup of cholesterol burden within the wall of the artery that eventually can occlude in some people and cause a heart attack. So that's what we don't want to see. So when they are saying mild coronary plaque, I'm guessing that means that there isn't a significant narrowing of that blood vessel there. So there's good blood flow. I think if that was more than there wasn't good blood flow, they probably would have had an intervention with a cardiologist instead of posting this question. So I'm guessing there's good blood flow through there. So plaque is that buildup that comes along there. And we know that that actually starts at a really, really young age now. There's evidence that that's present from much earlier on. We used to think of it as just a condition of the older folks, and it's not seemingly be the case. And so how does that happen? Well, there has to be damage to that blood vessel wall. And we're just starting to learn about really what's causing that damage. And there's essentially a milieu that's happening within the wall of the artery that is created through having inflammation present that leads to that damage. And then it's susceptible to start having cholesterol start to build up in there and over time accumulates. So when we have that mild amount of plaque, it still means that there's plaque. And we're not just worried about here, we're worried about up here, we're worried about everywhere else. It's not necessarily it's just isolated to the heart. It's just that if you have a heart attack, that's can be life-ending. But if you have a stroke, that's also could be significantly life-altering, if not life-ending too. So we want to think about it full body. Having excellent fitness is a fabulous baseline because what that tells us is that you're probably already getting in good aerobic function of your heart. So your heart is a stronger muscle at baseline, which is good. It also means you probably have lots of nitric oxide being created within your blood vessels that keeps them relaxed and not tense, creating high blood pressure. So all of those are good things. But right now, the best evidence we have truly comes from the medications that we have. So statin therapy being first and foremost. In this functional and integrative world, we try to think outside of the pharmacy box. And so there are some supplements that are used, things like red yeast rice and plant sterols and bergamot and berberine to try and lower cholesterols, because if you have less cholesterol around to build up in that plaque, then you can have, less buildup from that standpoint. They don't necessarily target the inflammation that may be underlying. And why is that inflammation there? And that's things we talk about all the time in terms of hitting gut health and heart health and sleep and nutrition and all those things. There are supplements that we might be able to target at inflammation as well. But at the same time, those don't have the same robust evidence behind them as we're going to see with a lot of the medications. Now we try to think beyond just statins, of course, and we do have some really exciting other medicines that are lowering cholesterol just as, if not more effectively. So you may have heard of the PCSK9 inhibitors, or even something new called bempedoic acid getting released. And there's even more in the pipeline. So that's really exciting that we're able to do this, and maybe those that are hesitant about statins may be more open to those. So when it comes to truly best evidence, that's where it lies, is in those interventions. But when we want to say, okay, I hear you, I'm not a fan of the medication route, we understand. And so some of those other supplements that I've mentioned are ones to think about, but really then dig into your basics. And so nutritionally, we know that the Mediterranean diet has the best and most robust evidence for it in terms of heart disease and heart outcomes. So lots of fiber, getting your legumes, lean proteins, lots of olive oils, and minimizing the saturated fats, minimizing the processed sugars. Those are going to be really important. And then, of course, we do know exercise plays a role. I'll be honest, there is some little bit of evidence, and we don't know why that is, but there seems to be those that are doing long-term, long endurance exercises that we can maybe creating some inflammation. And I think that's a really sticky area right now, because I think there's probably a lot that we can't tease out from that. And I wonder about things that Stacy and I talk about all the time, which is under fueling and under recovery that may be contributing to those situations. So we'll let that stand aside, because there was a really cool study that looked at the Norwegian 4x4, which is 4 minutes of hard effort at 85 to 95% of your maximum heart rate, and 4 minutes of super easy as possible whether running or biking, those are the two main modalities. And you'd repeat that 4 times. And it's a really intense workout if you've never done it before, but very effective for building high aerobic fitness. It was studied in a group of men, and did have, when they scanned their hearts, they did have regression of that plaque when they rescan them after doing this for a set period of time. So that's a really exciting finding. It was a small study. It was a single study. So we can't lay everything on that, but does show you that certainly there's some power behind exercise. The other caveat with that one is it's not primary prevention, meaning these people had already had some sort of heart event. They either had a heart attack or something. So they were already pretty kind of down the line type of sick, versus, all of us in this room right now who haven't had a heart attack yet. So that would be primary prevention. So putting all those things together, it's still a very multifaceted approach to trying to, target that mild plaque. But I would offer that being aggressive and being forward with your planning of, targeting any inflammation, making sure we have good blood sugar control, getting in that exercise, but also getting in that recovery and getting sleep. All of those things really matter, because plaque that's there, and especially if it was the calcium score, that's already hard plaque. That's plaque that you don't really have to worry about. It's the soft plaque that machine's not measuring. That's the scary plaque that can cause a problem. So if it's there, I would say, the best evidence is to be aggressive and go forward and really have that conversation with your physician about whether a medication is right for you. And if it's not, that's totally fine too, but work on all those other pieces that we know are absolutely foundational.
Wow, awesome. You hit that question with every answer. That's really great information. Thank you. All right, that is all the time that we have today with the Tegrity team. So I want to thank everyone for joining us. If anyone has any questions that you do want our team to answer, feel free to leave a question in your comment section or on our socials. We have a link to a questionnaire that you can leave your question there as well. And if you are interested in working with the Tegrity Health team, I encourage you to check out our website, tegrityhealth.com. From there, you can book a free discovery call and just get to know the way that we could help you guys. So thank you, everyone, for your time. Thank you, Tegrity team, for answering all of our questions. We'll see you next time.